Well, welcome everyone. Good afternoon now. We're excited for our second learning session for the Constellation Regional Learning Collaborative. We have a presentation on accurate blood pressure measurement and self-measurement of blood pressure presented by Dr. Lackland and Dr. DePetty. But before we get started, I wanted to spend some time on just some introductions. Welcome to the Navant team. We do have another participant that we were hoping will be here, and maybe they'll be able to join later. But this is a clinical team that is part of our in-clinic pharmacist pilot program. We have the South Carolina Office of Rural Health, who is working very closely with them. And it's a Foothills Community Health Center in South Carolina. We just signed our MOU with them, so if anything, we'll catch them up to speed, and we hope for you to meet them in our next learning session. But again, welcome to the Navant team who are here. And again, our facilitators is Dr. DePetty and Dr. Lackland, who is also one of our faculty. So along with Shannon Chambers, who's also from the South Carolina Office of Rural Health. Welcome to our lead coaches, Dr. Butler, who Kathleen had mentioned earlier. Unfortunately, could not attend due to being in clinic, but he is our provider lead coach. We have Catherine Plunkett, who is our quality improvement lead coach, and Jametta Magwood Golston, who's our health equity lead coach. For our transformational coaches, welcome Sylvia, LaShonda, and Lindsay. Sylvia's here. She supports our Navant team, and LaShonda and Lindsay supports the in-clinic pharmacist team, Foothills. So thank you all for being here. And before I introduce you to our facilitators, a few ground rules or friendly reminders. Please mute your microphone when not speaking. We have someone who's monitoring our chat, so please feel free to use our chat function or the hand raise function during the session. And of course, if Dr. Lackland and Dr. DePetty prefers it to be engaging, they'll go ahead and prompt that as well. And then please note that all of our sessions are recorded and will be uploaded to our YouTube channel. All right, I'm so excited to share a little background about our presenters. Dr. DePetty is currently the Health Sciences Distinguished Professor. He was previously the Dean of the University of South Carolina and the University of South Carolina School of Medicine in Columbia. He's also an advisor for the Pan American Health Organization, HARTS, across Americas. And Dr. Lackland is a professor of epidemiology at the Medical University of South Carolina. He's also a fellow of the American College of Epidemiology, American Society of Hypertension, and the American Heart Association. Dr. Lackland is also involved in population high blood pressure control efforts and have contributed to over 300 scientific journal publications. So thank you again to Dr. DePetty and Dr. Lackland for presenting today, and I'll hand it over to you guys to get started.
Don, you're on mute. Don, you're on mute.
Hi, Dr. DePetty. We would love to hear what you're saying, but you're on mute.
You're on mute.
There you go. See, I thank goodness I don't have a remote control or a clicker. Thank you very much for the kind introductions for both me and I'll also speak for Dr. Lackland. What we planned for this afternoon was sort of a tag team with this presentation. It'll be very brief, so hopefully we will have a robust discussion. And I will get us started and to do let me just give a little bit of an overview initially as to why we're having this session today, why the importance and why are we devoting the precious time from the collaborative for this topic, which is accurate blood pressure measurements, of course. And then I'm going to let Dr. Lackland take it from there and really talk about the nitty gritty and some specifics about what we should be doing. If I could have the next slide. This slide I always like to show in some form or another because it answers the why, the why question. Why are we here? Why this presentation and why today? I was, by absolute happenstance, when I was at the University of Texas, I was chosen to go to a business school in the University of Pennsylvania called Wharton, and I spent some time there. And they taught me, I think, a really important lesson in terms of change. And what we're going to be talking about today, even though we're going to talk about accurate blood pressure measurements, what we're really talking about is change. We're changing our practices, changing our approach. In this case, of course, hypertension. And since hypertension starts with the blood pressure, let's start with accurately measuring the blood pressure. And they introduced me at Wharton, some of the faculty, to a person by the name of Cotter from the 1980s and 1990s. And he was an individual that researched and looked at institutional change, organizational change. In this case, it was industrial change. It was the United States auto industry. And that was at a time when the auto industry was making tons of money in the United States. There was very little competition, but several individuals sensed storm clouds on the horizon regarding, obviously, other auto manufacturers from abroad, from Japan, from Europe, et cetera. And Cotter developed 8 steps to organizational change that he thought, were important, and obviously has become well known for these 8 steps. But step number 1, and that's the only one I'm going to be talking about this morning, is for significant change on a personal level, or even an institutional or industrial level, if you will, is you must establish a sense of urgency or a burning platform. And you need to talk about and yell of this burning platform over and over and over at every opportunity you get. And that's why I always show this first slide, when it's appropriate, and it is today. And what Cotter said is that establish a sense of urgency, a burning platform. So that's the why. That's why we're here. So what is the burning platform? We all know the burning platform, but it's still important to talk about it and again, go over it and announce it again. And that is, of course, now globally. And in the introduction, I am a senior advisor to WHO and PAHO, and have been active globally in terms of the hypertension and cardiovascular epidemic or pandemic, if you will. So now, NCDs, non-communicable diseases, are the leading cause of morbidity and mortality globally, and including in Latin America and the Caribbean, where I spend most of my advisor role and time. And hypertension is the leading risk factor for cardiovascular disease, so it's the leading risk factor for cardiovascular disease globally. That's the beginning of the why. But the why comes into focus when you look at the control rates of hypertension globally, and we're going to turn our attention to our country very soon, the next slide or two, and that it would be okay if it was the leading risk factor, but it was controlled. But it's not, as we all know. Even with blood pressures of less than 140/90, we're only controlling 20% of the population globally. And what's really interesting is that's despite safe, effective, and affordable pharmacologic treatment. So what are we going to do? We're going to do what we're doing this today, and what we're doing with the regional collaborative. Let's start and continue a robust and honest discussion regarding how our current practices have not been successful. They've got us partly down the field. Absolutely, no question about it. However, they're not getting us across the goal line. So that means let's examine new opportunities to increase the control rates of hypertension. And that's what we're here about today. And you've heard this over and over again, that the definition of insanity is doing the same thing over and over again and expecting different results. That's sort of what we've been doing over the last 10-ish, maybe 15 years. And that's, again, answers the why. Next slide. Well, that was globally. And we can say, okay, but we're here. We're here in North Carolina. We're here in South Carolina. We're in the United States. This isn't our problem. And the answer is yes, it is. Obviously, on this slide, you can see that right in the midst of the pandemic, the COVID-19 pandemic, the Surgeon General said, stop. Let's stop everything for a brief moment, obviously continue the pandemic efforts. And he was referring to a recent NHANES data report that came out during the pandemic from the survey of 2017 and 2018. So what caused the alarm to cause the Surgeon General to announce a call to action for hypertension in the middle of an infectious disease pandemic? Well, until that survey, like I said, we've been moving the ball down the field, but very incrementally. So the last survey of 2013, 2014, as you can see on this slide, showed that we continue to increase our hypertension control rates nationwide. Incrementally, but still they were going up. And again, if we just continued the same track, they would continue to go up, and eventually we would get to a reasonable goal of 85 to 90% control rates. But unfortunately, that didn't happen. In the 2017-2018 survey, there was a dramatic wake-up call. And that is that for the very first time since we were measuring hypertension control rates, the control rates went down from 55-ish to 45-ish%, as you can see. And that's before the pandemic. They only probably worsened during the pandemic. That's using a blood pressure of 140/90. But if we use a blood pressure of 130/80 as control of hypertension, which many guidelines, starting with the American College of Cardiology and American Heart Association calls for, that would be a dismal control rate of only 19%. But again, some people would say, well, that's just a number, Dr. DePetti. Well, it's not just a number. Since hypertension control rates parallel, to an extent, cardiovascular morbidity and mortality, you would expect that perhaps they would impact outcomes. When control rates go down, outcomes would go up. And unfortunately, we're seeing a plateau of cardiovascular outcomes, particularly stroke, and perhaps even an increase that maybe it's not cause and effect directly, but I have to believe they're linked. Next slide. So what did the Surgeon General's call to action do? Well, it had 3 pillars. And again, this is in 2020 at the height of the pandemic. The Surgeon General called for making hypertension a national priority again. We were doing a wonderful job in the 1970s, 1980s, and 1990s when it was a national priority, but we were resting on our laurels. 2, develop and engage the community to cultivate community support mechanisms. Talk about hypertension everywhere where we work, play, and live. And again, optimize patient care, starting with specific concepts such as standardized treatment approaches, team-based care, etc. But all of these 3 pillars depends on one thing, the blood pressure. Since blood pressure is the phenotype, it would be wise of us to accurately measure the blood pressure if all our other treatment decisions, the diagnosis, the management, the treatment, titrating medications, lifestyle modifications, all follow the blood pressure that we measure wherever we measure it, whether it's out of the office, in the office, etc. Next slide. And again, I don't have to remind all of us that we're right smack in the middle of a pandemic, and the pandemic with an infectious disease like COVID and a non-communicable disease like hypertension and CVD are interrelated and are the perfect storm, as we've talked about in the past, and this study shows that one makes the other worse, and it's just a vicious cycle. Next slide. Well, how do we start with accurate blood pressure measurements? What's required? Well, there's several factors, and these factors are key factors, and again, we're going to delve into them in a greater depth, and I'm going to turn that over to Dr. Lackland shortly. Number 1, proper patient preparation. It's critical, and we're going to see that. You have to measure the blood pressure in an appropriate setting. That matters, whether it's home, an appropriate setting at home, or an appropriate setting in our offices or in our clinics, or wherever else we're going to measure blood pressure. And number 3, we have to have standardized treatment protocols with individuals that are trained and credentialed. the machine or the device we use. Since that's the bridge between us and the patient, and that blood pressure number that we're going to generate is critically important. And now we're recognizing that the key need to use accurate, validated, automated blood pressure devices that are oscillometric. And again, we'll talk a little bit more about that and what do we need to do to achieve that goal. Next slide. So this gets us into the heart of the action. We now know, of course, what's needed, and these are only the major pillars of what's needed. So really, what's going to be the unifying theme of both? Well, most of them are going to be education and training. You're going to hear that over and over and over again. Appropriate education and training and retraining, not just once, but continuous training, if you will. And then, of course, regulations and procurement, and getting information regarding validated devices where that information needs to be, which is to us, whether it's the organization, the healthcare system, if you will, and or the clinic, or even the home blood pressure monitoring that our patients now are being strongly advised to do in conjunction with office blood pressures. Next slide. Well, since I am an advisor to hearts, I will conclude with this slide, which sort of puts it all together. Wherever we get an opportunity, we like to talk about the hypertension clinical pathway. This is a one piece of paper, whether it's a big poster on a wall or a little postcard you can give to individual patients or healthcare professionals. It's called our hypertension clinical pathway. And it's sort of like one-stop shopping, if you will. It evolved around the pillars and the systems from the World Health Organization and our sister organizations, such as the American Heart Association and the American Medical Association, as you can see around the hypertension clinical pathway. But the clinical pathway is centered on three general principles with details. And notice the principle A, the very first A panel, and Dr. Lackland's going to talk about this obviously in greater detail, is accurate measure of blood pressure. It starts with accurately measuring the blood pressure, and it starts with panel A. You can do all the B, C's, and D's and algorithms and standardized protocols and fancy medications you want. But if we're not accurately measuring the blood pressure, it's probably not going to be robust and get us the most bang for our buck. Well, thank you very much for having me. I'm going to turn the rest of the presentation over to Dr. Lackland.
Dr. DePetty, thank you very much. And I'd like to maybe add to that previous slide. When we were first asked to do this on this very, very important topic, both of us immediately went to this work that comes out of Hearts and put together by PAHO and excellently described by Dr. DePetty. This is one of the model programs. There's lots of folks that talk about the importance of blood pressure measurement, and lots of folks have put it in there. One of the nice pieces that we chose was to go with this and looking at this hypertension clinical pathway as one of the real models that's been put together very nicely to turn around and adapt. So I think how we got here, I think is kind of a little bit important. Let's go to the next slide, please. And part of this, with this hypertension clinical pathway, and I know everyone's probably like me and Dr. DePetty for that matter, when we hear these words, we think, hey, we know how to take blood pressure. I think I can go out and snooze a little bit on this one. I already know how to take blood pressure. I'm using the device that's in my office, and it's a real good one, so I don't really need this. I know how to take blood pressure. I know how to measure it. And we all think like that. But what we're going to kind of go through today is some of the importance of, we know how to do it. We know the theory and the mechanics. This is offering a little bit of the detail that becomes so very, very important when we're going to be managing blood pressure. And I guess if I could add another word in here, taking a blood pressure that you trust so much that you're going to base the therapy that you're going to treat me with based on this is how important that you know that measurement is. And that's where we want to go. A couple of examples of some histories that we've had where somebody goes into a clinic and they've had 5 blood pressure measurements at a particular visit. And so we asked the question, what did you do with those 5 measurements? And they said, well, we selected the one that was most important, the one that we thought did the most value. Didn't take an average. So you basically took then at that point 4 blood pressures unnecessarily. We wasted time. We wasted enforcement. So this is kind of getting, how do we think about that? The top one is the accurate blood pressure measurement. Following these typical steps that you do kind of know, not letting the patient speak, keeping the support, the arm at a heart level, putting the blood pressure on the bare arm or near bare arm. Very important, using the correct cuff size, supporting the feet, keeping legs uncrossed, emptying a bladder first. No, I've been in that capacity many, many times thinking I'm going to do a urinalysis in a little bit. I'm going to save up, not be nervous. And then they're going to measure my blood pressure first, and on full bladder, that can really contribute to additional parts there. And also supporting my back or supporting the back of the patients. Very important, simple pieces that you have that we all need to take a blood pressure. A blood pressure, if Dr. DePetty takes the blood pressure following these 8 steps, Sylvia takes the blood pressure following these 8 steps. I take the blood pressure, I follow 3 of the steps. Well, my blood pressure is not the same as what the others have measured. Another important piece that's come about lately, and that's the cardiovascular risk, determining the cardiovascular risk that fits in. If you look at the ACC/AHA guidelines and many of the new guidelines, it requires that cardiovascular risk in determining whether or not you're going to treat a particular blood pressure. So without the cardiovascular risk, the accurate blood pressure measurement is important, and it's great that you have it, but your determination of treatment is really going to also include the calculation of the cardiovascular risk. And we'll move to the next slide. So we, again, think about this. We've gone over these. So important in the general preparation for everybody, all members of the team want to have a good idea with these different pieces, these different parts that are there. Give a slightly perhaps amusing type of scenario. We were with a particular clinic one time, and we were talking about. I said, can you have some special cases that we might want to kind of look at? He says, yeah, we had a person today that came in, nice young man came in, but you could detect he had been drinking alcohol. And this about midday for a blood, and he came in, measured the blood pressure. Blood pressure was a little bit elevated, and they said, have you been drinking? And he said, yes, I have been. And he said, well, okay, how much did you have to drink? He said, actually, I sat in the parking lot right before I came in here and drank a 6-pack of beer. I said, okay. Well, that's going to be affecting your blood pressure. He said, just out of curiosity, why did you do that? And they said, well, I figured I was going to get a prostate exam, and I wanted to be mentally well prepared for the prostate exam. So these things happen that affect blood pressure levels, that affect different areas, and things that we have to be considered about. Very importantly, as we look at this, to have that validated blood pressure measurement. Next one. This is a really neat slide that's saying in here. This is looking at how well do we do it. Multiple blood pressure readings, really only 15%. Deflation rate going out there that's doing it properly, 15%. Patient position, 25%. Arresting blood pressure, only 35%. What is that saying? That 65% of the blood pressure measurements, the person was not resting. Maybe had just stepped down, had been walking around, coming into the room and do it. Had doing a palpitation, 45%. Arm position, Karadikov sounds, this is when we're taking a manual blood pressure measurement. Bilateral readings, a little bit better. And arm support, we're doing a little bit better at that. But if you were going to say a validated blood pressure, a blood pressure level that you trusted, if we looked at these different these levels, would you trust this blood pressure? And we haven't even almost got to devices yet and the equipment pieces. This is just simply on the process of measuring the blood pressure. A very dear colleague of mine and Dr. DePetty's, a fellow, Dr. Ray Townsend, who's up at Penn, did a little simple study looking at medical students and following them, looking at these types of procedures. How well are fourth-year medical students, how well do they measure blood pressure? And he found very, very similar and published very, very similar findings very recently of how well do we know to measuring blood pressure and measuring it properly such that we could trust the value. Next slide. Now we get to the devices all over the place. These are the ways that we typically will measure blood pressure. There's the aneroid and mercury manometers. Mercury, simply because of having mercury, or you're seeing less and less, even though mercury is basically the gold standard. We have home self blood pressure monitoring all over the place. And again, we can put those in two categories: validated and oftentimes unvalidated. Very, very popular, what most all of us use now: automated blood pressure devices, digital blood pressure devices. Again, some validated and superb instruments. And then there's also ambulatory blood pressure monitoring. Again, most are validated, but again, kind of an expensive piece. So you have a large selection of choices as to what particular device you would like to bring forward. Next slide. Again, we're putting back in that category. Okay, we want to make sure that we're using accurate, validated devices. Very important. It's critical to kind of look. There's many, many links about now that you can go and find, is this device validated that you're using? And we can bring this. And this is also true with regards to home blood pressure monitorings and devices. You can recommend to your patients the actual home validated devices and making sure that those are there. Many, many are. Many have great Bluetooth capability. There are many of the devices where your patient could be taking a blood pressure at home. I could be taking it home. You want to make sure I'm doing it properly, and you want to trust that I know what I'm doing. So I'm sitting maybe same time all the time. I can now punch a button and have my blood pressure records moved into your electronic health record, as whether that be Epic or many different ways. Great use of technology. But all important, if I have a validated device, I equally want to make sure that it's a calibrated, validated device. Very important that you're constantly measuring, making sure that that device is still calibrated, making sure that my cuffs are not worn out, that they're being apart. Next slide. With the automated devices, this is the direction that we're going. And this is due to some of the other issues with a lot of the other devices that we had historically used. And so I kind of want to focus in that the automated devices, they're developing itself very nicely, and that automation really makes things more efficient. These are good, validated devices when you select the right one. They also have a lot of capability of taking more than one measurement. Some can be assisted, not assisted, or observed. A lot of different ways. And the same way with looking at the automated devices for home blood pressure measurements, which will now allow us to take a good look at that white coat effect. So good, validated, automated devices that we can also constantly looking at to make sure that the calibration is good. Next slide. Again, this is the piece that we go back in there. We know we want to do validated devices, but it's really kind of looking like that 20% of the devices that are on the market today, the automated devices for the most part, are only 20% are validated, or less than 20%. It's getting better as we look at more and more, but pretty much you can put anything you want on the market, but it's important to know for you to be able to have a value to trust. This is also extremely important for your home blood pressure monitoring. You know, you're asking your patients to measure their blood pressures at home. They're providing you with these home blood pressure values, but if they're in an unvalidated device, you can't trust them, so you can't use them. So I guess it increases awareness of blood pressure and allows the patient to participate, but you want to have a validated blood pressure measurement that you trust, that you can now incorporate in your management. Okay, next slide. If we look at these other types of aspects, the availability again of these devices that are worldwide, this just kind of brings in the concern that we have with making sure that we use a validated device. And it's not okay, unfortunately, to just assume, well, it's a device that's sold at a pharmacy or CVS or at Walmart, readily available. It looks like, and it's also not, if it just comes from a validated a company that you they have some validated devices. It really is up to the owners to make one member of the team to take a look at the device that you're currently using in the clinic, but also the device that the patients are using for their home blood pressure monitoring, and doing a quick check on a number of different websites that look at validated devices and determine, is the device that the patients are using and that you're using, is it validated, and doing that type of additional work to make sure that that's the case. Next slide. Again, we've spoken about this. This is why Dr. DePetty and I were excited about the work that comes from Hearts. Again, the excellent posters and stuff that show you proper blood pressure measurement and things that you can actually look at, very simple to have. It's even been in many pieces that we would say, what if you took one of these posters and put it in each of the examination rooms, so that everybody is reminded, all the members of the team, because different members of the team are measuring the blood pressure. So having this kind of stuff, say, this is the way that we standardize our blood pressure measurement, and we're all doing basically the same thing. We know everybody knows how to take blood pressure, absolutely. And this is just a process of trying to get it standardized so that everybody's blood pressure is the same. And so that we can have, if we've taken 3 blood pressure measurements at a visit, we can maybe take the means of those 3, or we can look at all 3 of those and see how all 3 trusted blood pressure measurements can make its way into the management of blood pressure. Next slide. A little bit more. This is some of the other pieces that are part of the Hearts program. There are virtual courses that you can take, little simple webinars and videos that are just really nice and easy to take a look at, bringing these pieces forward. There's other materials as well, but kind of making sure that all the members of the team are taking these pieces and learning different aspects, and at least everybody on the same calculator. Certainly with blood pressure measurement, outstanding. Also, how to take that cardiovascular risk, which is a critical piece of one of the measurements. If you have blood pressure measurements, you also want to have the cardiac risk. And taking advantage of these readily, easily, free, available webinars, et cetera, that can also help with the blood pressure measurement and that kind of standardization part of it. Next slide. Again, a piece like this, and I would say the Hearts protocol is one of the best that's really here. looking at accurate blood pressure measurements and the self blood pressure monitoring, the home blood pressure monitoring. You want to increase that. The whole idea is putting these two together, validated devices, standardized preparation and procedures that we're going through, recognizing all members of the team to having these standardizations, this kind of certification, if you will, putting all that together, combining that with self blood pressure monitoring, we will all agree the more blood pressure measurements that you have on an individual, me, whatever, the better you are to really understand my blood pressure levels, being able to manage my blood pressure, control my blood pressure, and probably the more likely I am to determine to be a part of the program and learning if my blood pressure is under control, needs to have a little more work, or is changing. Building all of this together with the team can be very, very effective. And again, we're kind of standardizing the team operation. Okay, next slide. And that's where we kind of are. Dr. DePetty, can you tell me what I messed up?
Oh, I would never do that, Dr. Lackland.
Thank you.
It was too clear. And again, I appreciate you going into the details. I think the bigger question is to the group
Yes.
here today. Good, bad, or ugly? I saw some chat, things coming up during the presentation that was like, oh my gosh, how can this be true? The problem is it is true. 20% of blood pressure devices are only validated, and and it doesn't matter which brand. Even within a very well-known brand, maybe 50% are validated, but that means 50% are not. And that's why Dr. Lackland did mention that there are various sites you can go on. The AMA has a very, very good site. PAHO has recommendations. Medival, you saw that from Dr. Sharman from Australia. None of them are that easy. However, if you start using one, you sort of can get used to it, et cetera. But nevertheless, it's striking when you really look at the data that we showed today, and that only 10%. By the way, that study from Dr. Townsend that Dr. Lackland made, that he made reference to, it's startling. These were fourth-year medical students, U.S. medical students, that out of 300, only one took the blood pressure properly. That I almost fell over. And as a former dean, I was embarrassed.
Is there, Dr. Page, I might add one more slight anecdote with these kinds of stories. Another little quick story. We've spoken about devices and validated devices. It's so important, and I will share a story from my mother. God rest her soul, but she wonderful person, and but she found a device, I don't know where, probably in a store somewhere, where she would take her blood pressure with her finger, and so she was hypertensive and needed to have the management, but she found this little device and she'd put it on, and I said, please don't use that. That makes me look really, really bad. I said, this is just a little piece of junk. And she said, she said, well, it gives me the blood pressure values that I want to do. She said, well, I put it on my finger, and if it looks like my blood pressure is high, I'll just take it off and I put it back on again. And she said, probably in a minute, it's regular now. And she said, that's what I tell my doctor. Now, we corrected that for those that are going to get on me, but there's so many different things that claim to measure blood pressure, so many different devices. It's so important that people are being inundated with this value. So this validation of devices and also the proper procedures for measuring it. So if I'm measuring my blood pressure at home, you want to make sure I'm using the right device. You're wanting to make sure I have the cuff that's appropriate for my device, and for me, and you want to make sure that I'm doing what you asked me to do. You might even want me to do it in front of you. Bring my device, take my blood pressure, show you that I'm doing the same thing. My feet are on the floor. I'm resting. I'm not talking. I'm not eating. And I'm taking my blood pressure like I would take it in the clinic that you want for the validated devices, and making sure that I'm doing that. And if you trust me, then maybe you could trust my values that I'm going to be providing to you.
Oh, absolutely, Dr. Lackland. And again, I might just reinforce that on the last slide that Dr. Lackland showed, PAHO has a site for certification. It's only
Yes.
20 to 30 minutes, and almost 300,000 healthcare professionals have already taken the course and been certified regarding taking the blood pressure measurement. So it's out there. We can use it as soon as we hang on. We end this. If somebody wants to go right on it and sign up and take the course, but this is not complicated.
Yes.
But again, it's change, and that change starts with that burning platform. If we're going to act on a blood pressure measurement, don't we want it to be accurate? Don't we want the device to be validated? I was thinking about this just the other day. There was a paper that came out about arm position. And Medscape called me and asked me to do an interview to talk about that paper, which I did. And the minute I hung up, I said, wait a minute, what if this was a blood test? What if I was going in and I was getting a blood test that was going to totally change or initiate therapy? Wouldn't I want that blood test to be validated and be accurate, and that my physician or healthcare professional could rely on and then act upon it? And the answer is, of course, we would. Well, it's the same thing with the blood pressure, and I never thought about it that way before. Shame on me.
Thank you. Sydney has just posted the link for that course. Dr. DePetty, Dr. Lackland, I think all of us are in the consensus that was, I mean, that was my biggest takeaway from this session. The importance of using making sure your tool is validated. And I just added a comment that, I see similar to your story, Dr. Lackland, my mom uses a similar cuff, and she finds it so easy because it was like in the catalog of items that she can get in her Medicare plan. And, a lot of people are using that in her provider's office. So, educating them on, maybe doing it the accurate way, not the easier way, is really important. And she suffers from high blood pressure as well, too. So, that great insight, great discussion. And I just want to open it up to the team. Before I do so, though, I want to just thank you guys for this very insightful presentation.
I was just going to mention that, it's an expense, right, to purchase a blood pressure cuff. And if somebody already has a blood pressure cuff at home, and you feel like it's not an accurate reading, it can be difficult for some people to go out and buy a new approved blood pressure cuff. So usually, like, what I tell people to do is I'm like, chart your blood pressures. When you come to the doctor, we'll look at your trend and then bring your blood pressure cuff, and we'll kind of compare it as to like what readings we get. Do you have a better suggestion? Because there's not, like, we have what's available to us. I'm not sure if that's the right thing or not, but I feel like it's better than them not checking it.
I agree. And also, boy, how do I feel whenever you tell me, oh, well, you've been taking it on that device. I know you paid $100 for it, perhaps, and you need to throw it away. Well, I'm kind of angry, not you personally, but I'm angry at you. I'm annoyed. Yeah. Well, I'm not going to listen to you anymore. You told me to go measure my blood pressure at home, and now I did, and now you tell me you can't use it and that kind of stuff. I think the approach that you have, and I'll give you a similar one that we had an experience with one of the clinics. This one particular clinic, they had a number of obese hypertensives, and the traditional home blood pressure device. Well, I'll be very specific. So the Omron 700 series did not have an extra large adult cuff. And so they didn't have a cuff size for it. A good device, validated device, but there was not a proper cuff size there to kind of fit it. So an alternative was, well, why don't you use the wrist device? Or this one person had a wrist device. So the providers at that clinic, they said, I just, blood pressure is for an upper arm blood pressure measurement. That's what we manage blood pressure. We don't do it to a wrist device. So they said, but what they could use, so that they didn't tell the person, well, you just wasted all of your money. You just went out and bought a wrist device, and that's going to be pretty on your arm, but we can't use it. They didn't want to tell the patient that because they figured the patient wouldn't come back. They'd go somebody else. And so they did what you did. They said, well, we can't use it for specific treatment, but what we can do is to kind of see how your blood pressure going up and down during the day? Are you seeing some spikes or some pieces like that you could, so you're incorporating the patient into their care, making them there, that awareness, but you're not, I hate to say trusting that value. You're not trusting the value such that you would change a therapy for it, but you're bringing it in with the idea that one day when you're able to replace that wrist device or add to the wrist device to work on a validated home blood pressure monitoring. Dr. DePetty, I know you do this too. Is there some pearls that you might add to that too?
No, I absolutely sympathize with Erica. That's exactly what we do. You do what you can. You do what's best for the patient. I think that was interesting to me when I started looking at validated versus non-validated devices. The cost didn't seem to be different. Now it would be new if you had an old device and you had to throw it away and buy a new one. But if it's the initial decision to buy it's a new patient, et cetera, or you're just introducing self-monitoring of blood pressure or home blood pressure monitorings, it was interesting to me that the cost wasn't different between a validated and an unvalidated device. What drives the cost up is the buzzers, whistles, and bells, that manufacturers are now putting in the devices because they can, and they're useful, et cetera. But I was intrigued that the initial cost wasn't different. $35 or $40 get you a validated device, and $30 or $40 get you an unvalidated device. So go to the sites, go to the AMA site, et cetera, or whichever one you want to use, and stick with it, and you'll be surprised.
Sir,
All right, thanks, guys.
I'm thinking that those are great teaching moments that you brought up, Erica, if they don't have one already. I know you're talking about if they already have one, but being knowledgeable as clinicians, being knowledgeable and educating patients that you're recommending to buy one so that they do buy one that is validated. And then the other issue, and this is something way back from my public health days when we used to run community clinics, making sure that even the blood pressure monitoring devices that we use were accurate and calibrated. And how often were they calibrated? Because especially if you're taking them out and about and they get cold in the car or they get warm in the car, they need to be recalibrated. And I have periodically asked in my own provider offices, the person who's taking my blood pressure, don't you want me to put my feet on the ground, like trying to cue them on those, the steps to take an accurate blood pressure. And then, I've periodically said, any idea when this device was last calibrated? And most of the time, the person taking my blood pressure doesn't even know what that means. So I'm struck with so many teaching moments, not just for patients, but for clinicians and even providers. The example you gave, 1 out of 300 fourth-year medical students knowing how to accurately take a blood pressure. And then we're making, as we said in the chat, we're making recommendations for therapy, for treatment based on inaccurate measures. So I'm struck with so many teaching opportunities that we have based on this presentation. So thank you. And something that our team really needs to talk about, How can we be more proactive with getting this really important information out to folks who need it? Providers, patients, families. I know we have Rosa on, who's a pharmacist. Sometimes it seems like our pharmacists are more informed about because they're sometimes in their practices, they're taking blood pressures. They're also making recommendations to providers, making sure that we're not just talking about physicians and advanced practice practitioners, but also our pharmacists and others. Like, how can we get this word out to patients and others who really need it, to make sure they're purchasing the correct devices periodically, they're calibrated and that kind of thing?
Well, Sylvia, this is Don. I can't agree with you more. And it starts with the patient. That's why even a little card with those 8 positions, et cetera, whether it's PAHOs, or whomever give it to the patient and have the patient learn that when they go home, so they can teach themselves, as well as the certification programs that are only 20, 30 minutes. And I'm not exaggerating that. That's really all they are. I want to follow up on one more point, though, Sylvia. When you talk about calibration and validation, they're 2 different things. Validation is the manufacturer is guaranteeing that they've gone through the proper steps to make sure that blood pressure machine of that model and that number is accurate. Calibration is different. Oscillometric automated machines do not have to be calibrated. Matter of fact, they can't be calibrated. It's the aneroid, the manual devices that Dr. Lackland showed on that slide that have to be recalibrated every 6 months. And of course, they never are. So the good news is that the oscillometric validated automated blood pressure machines do not have to be calibrated because they can't. But then the bad news is, I asked the question, actually, I think that this was in Antigua, where I was recently at a PAHO conference with one of the clinics. I was asked, well, if these oscillometric machines don't have to be calibrated, then, well, how do I know if they're still good? And I was, whoa, that's a good question. No one's asked me that again. And I looked it up and I asked around, and the party line is about 2 years. There's no answer to the question because they're not revalidated because they can't be recalibrated, et cetera. But nevertheless, good news, don't have to be calibrated because they can't. Bad news is that we don't know if they go out of validation, et cetera. Look, like you said, with moving them around and just longevity. So that was interesting to me, and that was new to me.
Thank you. It's all great discussion. I'm feeling more educated myself.
All right, thank you. Jametta has asked a question in the chat. In what circumstances or settings is SMBP not ideal, if ever?
I'll let Dr. DePetty, I would say if the patient is not able to do it, just either physically or mentally, and they don't have the kind of support to do it, then it's probably not going to be not going to be useful. We had a situation here where we were actually giving home blood pressure monitors to post-stroke patients with the idea for them to measure. And then we realized that there were some of those patients that they just really weren't able to use that device. And actually we were correct. They couldn't use the device. And I think it offered a little bit, perhaps of some frustration. And then what do you do if you don't trust that device? And here's your patient coming in with attempts to do it. But if you don't use it, it kind of makes it there. You say, well, I brought you in all of these blood pressure measurements and you just looked at it and kind of put it aside and still did it. You want to make sure that that they're able to take blood pressure measurements that you can trust. And again, validated device, but also being able to implement the procedures that you have.
I agree, Dan. The only thing that I almost think, I can't think of an easy one that says you should not do a self-monitor or a home blood pressure monitor. I think that's the answer to that is everywhere, anywhere possible,
Absolutely.
providing though that they're physically capable or have a family member or a support person take their blood pressure and or they're going to do it properly. If they're just not going to do it properly, yeah, I don't think that's going to be useful. We haven't had, I haven't had that come up too
I
often.
agree.
It's usually been on my end, not teaching them, properly, or on our end, not teaching them properly in the first place, like we're not teaching ourselves properly.
Right.
Maybe hope that helps.
No, that was very helpful. I was just thinking about different home settings and circumstances. And, I can imagine if I took my blood pressure at home, sometimes it might be elevated. So I was just wondering what circumstances, but no, that was perfectly answered my question.
And I have a question that kind of piggybacks off that a little bit. So how would you respond to someone who wants to implement an SMBP program, say like a pharmacy or what have you, but they're nervous about the responsibility of the patient's health falling on them? How would you respond to them?
I think it's I can say I know Dr. DePetty has a lot of experiences too. I don't think that's going to be a major issue. You would want to monitor it much like we do with our health screenings and this kind of piece where they would want to know what the value is, but so important that they go back to their their primary healthcare provider and provide those kinds of names. So you would have that in part of that instruction. If you see a blood pressure, I just made this up, that's high all of a sudden, or certainly in that the old emergency blood pressure levels, you certainly want to seek care out immediately. But if you see an elevated blood pressure, you want to report that blood pressure as the proper process to your primary healthcare provider. And so in this case, if it were the pharmacist providing that, they're facilitating the process of home blood pressure monitoring in the total care of blood pressure. Dr. DePetty, that's how I would think about it. Is that how you would approach it as well?
Yes, Dan, that's how we approach it. The liability is, everybody's always going to, think about that. But as long as you recognize the blood pressure levels and you actually, it really helps having the pharmacist do this because the pharmacist is even more likely to facilitate the feedback back to their primary care physician because they're doing that for other reasons, for prescriptions and refills, et cetera. So as long as you do that, that component, obviously attempt to either instruct the patient to tell bring this back to their personal physician and or you do it through your own system or your own connections, et cetera. I think it's going to be perfectly okay. We're now doing this in barbershops. So, and it's the same situation. Obviously they get some instruction to tell their personal physician or whomever their provider is and make sure that last connection is made. Should be okay.
Thank you.
I'm thinking out loud with you here, but whether it's in a pharmacy or at home, one of the pieces of information, and it's covered in the 8, but we don't think about, and Jametta gets back to your question and your comment about, if I take my blood pressure at home, sometimes it is like not going to be good because of everything that's going on in the environment. It might be, some people, myself included, I have white coat syndrome. I go in and I'm just worried about how my blood pressure might be. But then some people, it's so much calmer in the clinic or in the provider's office than it is at home because their home tends to be in turmoil, and that might be one of the issues that keeps their, blood pressure where it is, a lot of stress and that kind of thing. So just making sure another teachable moment, whether it's in the pharmacy, whether it's at home, wherever it is, that we calm ourselves as much as possible, that we're not engaged in a stressful conversation, or we're not taking it in the middle of the living room where there's, kids running around and all kinds of things that happen at home, especially with multi-generations living together. So just making sure that we're in as quiet, we're not having conversation, we de-escalate as much as possible.
Yep.
Because
It's the
that's what
same
I see. I
advice
think back to my years of doing this in the home, with community health and home health and that kind of thing. And what I would see in the home, and I'd be, oh my goodness, and you're trying to teach somebody to take a blood pressure and they can't hear, and all of those things that we have to take into consideration when we're educating.
Sylvia, absolutely. But I was just gonna add it, not to make it more complex, but it is a little more complex. There is such a thing as masked hypertension. And that is where your blood pressure is elevated at home and it's actually normal in the office. And that's as serious as having hypertension in the office. So we're taking home blood pressures not only clues us into white coat hypertension, which is more benign, although maybe not completely benign, but this entity called masked hypertension, where it's reversed. The blood pressure is high at home
Absolutely.
and normal in the office. That the data on that is clear. That's serious, and that has to be treated and approached with the same seriousness, if you will, if the blood pressure was elevated in the office. And that's about 10% of our population. If we didn't do home blood pressure monitoring, we wouldn't have even discovered that. Dan, would you like to add to that?
Look, I think it's Don. I think that it's absolutely correct, and I think Sylvia also want to say that's so important. You're saying you want to measure blood pressures pretty much at the same time every day that you're measuring the blood pressure, at that calm and following those kind of procedures. But as Dr. DePetty said, the home blood pressure, the out of clinic blood pressure measurements are actually it's almost critical for both MAST as well as white coat hypertension. And when you have those values that are trusted, like Dr. DePetty saying, all right, so if I'm a MAST hypertensive, oh boy, this is really invaluable. So now I'm treating somebody, I should bring somebody in a treatment that I didn't know before. And so now I'm preventing a stroke, and then I'm not over treating the white coat hypertensives like Sylvia and I, that are part of, or we're properly treating the white coat hypertensives, perhaps. I think it's a critical part of the blood pressure management.
And it's why it's so important to look at both the readings that are taken at home and in the clinic or provider office, and then asking those questions and using, team-based care, because I'm thinking when you have that 10% where you identify that their blood pressure is greatly elevated at home, and it's pretty normal when they come into the doctor's office. So that's where we have Sydney on as our excellent community health worker, where you might want to get someone to go into that home and, assess what they're doing, when they're doing it, but what else is going on in the home. Develop that relationship to figure out what are those stressors that are causing they can look at the device if they're not bringing it in with them, but they can also help to assess what other issues are going on in the home that's causing them to have those elevated readings at home, and get to the root cause of those issues. As that's oftentimes as important or right there with it as giving medication, is knowing what is the root cause and trying to deal with both medication and getting the problems resolved, and then you might not need the medicine anymore.
Sylvia, that's true, but again, I'm just going to reinforce it. There is such a thing as masked hypertension, where those blood pressures at home even though there may be a root cause, those blood pressures lead to poorer cardiovascular outcomes and need to be treated.
Absolutely.
So that's another reason why
Absolutely.
self-monitoring at home is important, because now we're discovering this 10% group of quote unquote masked hypertension. In other words,
Absolutely.
what I'm urging is not just to dismiss it because it might be because they may be real, and that's a real entity.
Yeah, for sure.
Thank you all for the great questions and discussion. Before we close out, any final comments or questions? All right. Well, I want to thank you, Dr. DePetty and Dr. Lackland, for a very engaging and insightful presentation. Should any of you have any follow-up questions or comments for Dr. DePetty or Dr. Lackland, please do contact us at our email that's presented on the screen. And I want to thank my team for helping to bring this presentation. And thank you again to Dr. Lackland and Dr. DePetty for taking your time to present to us today. Have a wonderful day, and thank you again.